Our first speaker in this session is Dr. Judi Woolger, MD. She's an assistant professor of clinical medicine at the Miller School of Medicine. Dr. Woolger earned her medical degree at the University of Florida and completed her medical residency at Jackson Memorial Hospital. She holds joint appointments in the departments of orthopedics, neurosurgery, psychiatry, and surgery. Among her clinical interests are nutrition, cardiovascular disease and prevention, health maintenance, preoperative care, and women's health. Dr. Woolger is a contributing author to the recently published book, Preoperative Medicine, Just the Facts. She is a fellow of the American College of Physicians and has been listed among the best doctors in America for 6 years in a row. We are very proud to welcome Dr. Judi Woolger.
Very much. Thank you very much. It's very nice to be here. Thank you to Immuno Labs for asking me to come. Let me say that when we set this up a few months ago, I was expecting to be able to present some data to you from a research study that we have going on, and we don't yet have all the data. So I was going to spend just a little bit less time today. I know Dr. Warden needs a little bit more time with her talk. So I'm just going to describe to you, sort of whet your appetite for next year about the results that are coming, and sort of describe what we have decided to look at and the reasons why. I do practice internal medicine at the University of Miami, so I'm one of those backwards people that you guys all talk about. We're very slow to come around, but some of us are. I guess what's happened with me is sort of as Dr. Laval described earlier, I was one of those people who was sort of sitting in my clinic writing the prescriptions for people and having the same conversation over and over. You know, your sugar's a little bit high, you really need to exercise and you really need to lose weight. And they'd say, yeah. And I'd say, you know, if you don't do this, we're going to have to put you on insulin. And they'd say, yeah. And I'd say, okay, come back in 3 months. And then they would. And then we'd have the same conversation over and over again. And I was bored, and I think they're bored, and we weren't making much progress. And about the time I was really getting bored with that, I also got a little bit more involved with the bariatric surgery patients who I was watching, of course, melt away the pounds after this surgical intervention. But it became so crystal clear to me. I mean, I think I knew it intuitively, but it became so crystal clear in front of me that what you eat has such an impact on your health. And it's like medicine has forgotten that. And you guys are maybe in tune to that, but the rest of the medicine group I don't think has caught on to that. And so last year, fortuitously for me, as my company said I should come here to the conference, because I was switching over to the executive medicine program that we were starting, and we thought this type of program would help us build some corporate programs that we wanted to get going. And I became very interested in the Bloodprint test that can be done to look at food sensitivities. And I went up to visit Immuno Labs, thought the work that was being done there was fantastic. But because I was trained back at the medical school, I did have to look and see where's the evidence. I was still, you know, kind of feeling like intuitively this feels like a really good program, but let me see what the research is showing to see if I can put it into play at the university. And the literature, although good, was a little bit dated. It was from the 1980s. So that's why I thought maybe we could update that information, retest some of this, and put it into play. Let me just say the one other thing that sort of forced me that last step to do research, because I've always been clinical, I've been on the clinical educator track. Research has not been my main interest. I had a patient said to me from one of the gynecologists, a patient that he had saved the life of the woman. She had uterine cancer. He did a surgery. This was about 8 or 9 years ago. And she had radiation, which was a standard of care, follow-up treatment, and ever since then, for the last 8 years, she suffered from radiation enteritis. Terrible diarrhea, 8 to 10 episodes per day. She had already seen the gastroenterologist, already seen the colorectal surgeon, had her colonoscopies done. Nothing could be found to help her. I had been at the conference and said, you know, perhaps we could look at some food sensitivities to see if we could find some ways to make you feel more comfortable during the day, since we can't reverse the damage that was done anatomically from the treatment we gave years ago. She came back in 2 months later thrilled because she finally had control over her bowels. She felt like she could travel again, and she was feeling as though this had been a big success. She wasn't normal by any, you know, she still was going more frequently than she wanted, but a dramatic improvement. So I was happy. She went back to see the gynecologist, and he said, "What doctor is practicing this voodoo on you?" So I said, okay, that's it. We need some research. Maybe if I hand someone a paper, then we can show them that this is really happening. So that's sort of my background and why I got interested in doing this study. And I've got a few slides here. We had some trouble deciding which diseases we would look at first with this, because there's so many things we could have picked. We heard about Sjogren's, arthritis, a lot of inflammatory processes. One thing, of course, I was working with the obese patients with the bariatric surgeon, so that was sort of near and dear to my heart. So one of the groups that we're looking at is the obese population, certainly multifactorial. And I don't think a food sensitivity test is the only thing that's going to solve that issue, but it could be a piece of the puzzle that we work on. When we look at categories, there are classifications from the World Health Organization. In our study, we're picking the ones who are in this category that's overweight or moderate obesity. I just felt like the people that got into the super obese categories probably had so many other multifactorial issues that it was not something we wanted to jump on first thing. Now, it may be something we do in additional studies, but not right away. I suspect most of you have seen this series of slides, so I won't spend a lot of time on them, but as you look through the course of time between 1985 moving forward, if you can read where the percentage of people who are categorized as obese in the United States continues to rise at a frightening rate. And as we move to 1990, we actually, in I think it's 1996, we have to get a new color. There, 1997. Because more than 20% of the population in those states have matched the criteria for obesity. And it continues to worsen until, again, we had to find a new color. So, and you know, if this was an infectious disease, if this was tuberculosis, if this was, you know, something communicable, I think we'd be paying more attention to it. But this is real, and this is affecting our country. And it's going to affect us in a lot of ways, because the cost of taking care of an obese patient is dramatically higher than taking care of a normal weight patient. And we could bankrupt our medical system if we don't start looking at ways to attack this and to bring it under control. Here's some of that information with the numbers that we were told. Remember, yesterday we were told to always have numbers if we instead of just the yeah. So some of our statistics, when a body mass index is over 30, there's a 55% increase in mortality just right off the bat, and a 75% increase in stroke, increase in diabetes of over 400%. And there's the same information in a graphical format, if that helps you understand it better. Again, the causes of obesity are multifactorial. Not going to be totally resolved with a food sensitivity test, but if we can get at some of those different components, the behavioral component, I think, you know, getting people to pay more attention to what energy is going in and what they're putting out, we may make some progress. A frightening statistic that in the 1990s we consumed 340 more calories per day than we did just a decade before. And I would like to thank you guys at Immuno Labs for the wonderful food we've had here. I thought they've been tremendous, great selections. It's really, really nice. And that's not always the way when you go to a conference. Sometimes you come home feeling like, oh, I didn't eat what I would have preferred to eat, but this has been really nice. We have the options here of eating fewer calories. Look how many more calories we're eating now than we did in the 1950s. And look at the food choices that are typically made available. In 1945, we used to drink 4 times more milk than soda. In 1998, we were 2 times more soda than milk. And that's true for children and adults. It affects all age ranges. A second issue that we're looking at on our study is the incidence of diabetes. It's certainly at an all-time high in the United States, affecting millions of Americans, costing us billions of dollars. The other two that I didn't do slides on were the issues of headaches and GI symptoms. So let me tell you a little bit about our test. As you've known from being in the conference already, there's a type 1 allergy that is the acute type of allergy, where immediately upon tasting a food or ingesting a food, you get a high reaction. It correlates to the RAS levels that we've historically done in medicine. But what we're looking at in our test is the IgG, or delayed food allergy response. We think that probably up to 90% of the food allergies are the IgG mediated, which is that delayed onset of symptoms. Problem with that for a patient or for a person who's suffering from symptoms is we're trained, say for migraines, a doctor might say, well, don't drink wine because it may contribute to your headaches. A person typically thinks about what they had 6 to 12, 24 hours before. They're not thinking about that delayed response that could be 48 or even 72 hours before, so they may not be very successful with the diet elimination process when they're doing it on their own. We now have the ability to test the IgG antibodies in a serum bound to the FDA-approved allergenic extracts, and with reliable methods, we can measure the level of response. And we get a scoring scale for the patient of 0 to 4, so they know where they stand in that scale. Our hypothesis in setting up the study was that participants would experience an improvement in their disease-specific symptoms if they eliminated the foods from their diet. And we have 200 patients enrolled in the study, enrolling in the study because they're not all enrolled yet. And we've divided them into 4 categories. We're looking for 50 patients who suffer from diabetes, 50 patients who are overweight, 50 who suffer from headaches, and 50 who complain of GI upset. For the headache and GI patients, we're looking for people who have symptoms at least an average of once per week, so that could be statistically significant. Just one episode of diarrhea in the course of a month is not the type of patient we're looking for. For the patients with headaches and GI symptoms, we're asking them to keep a diary 30 days before doing the tests, so that we have a marker to compare before intervention to after, and also whether they were taking any sort of medicines to help control their symptoms. Once they're enrolled in the study, they'll have their Bloodprint taken, although when we first did this, we had a 115 food panel. Now we have a higher food panel. I don't know if we'll switch that, but that's how originally we had it set up for the 115. They'll be required to attend a 1-hour session where we'll talk about healthy food patterns, the need for exercise, just sort of global lifestyle recommendations for everybody. They need to fill out a quality of life questionnaire, and we have validated tools related to GI symptoms and to headache measurement, so that we can use validated tools before and after their change in diet. And the same with the migraine therapy questionnaire, and the IBS 36 is a quality of life measurement. For the patients who have diabetes, we'll be checking standard ways we measure response to therapy, which would be hemoglobin A1C, urine for microalbumin, and fasting glucose levels. We're not at a point where, I know it was mentioned that we could do the postprandial insulin levels, and although that would be nice, it would have added dramatically to the cost of the study. So we'll just be doing these as a first run. And of course, all patients will be measured for blood pressure, body weight, body mass index, skin caliper measurements, those sorts of things. They're asked to follow diet recommendations that we'll be getting ourselves if we've had our blood drawn, the food avoidance and then food rotation diet. And following the patients, for the weight management patients, we'll check them every month. For the diabetics, we'll hopefully try to get them in once a month, because they could probably cross over into the weight management category. But at a minimum, the diabetics are asked to come at 3, 6, 9, and 12 months so that we can monitor. And the headache and GI patients will be assessed at 3 months to check for response. I think most exciting to me is that my experience with patients is I've seen this work so well. That I think we're going to get phenomenal results, and I think it leaves the door wide open to additional studies that we can be doing in the future. I think we could be looking at TNF alpha levels in the responders. We can look at IL-6 levels. We could be looking at ways to if people hit a plateau, find out if they're, just as was mentioned before, if they develop new sensitivities, then we can go after that and give them redirection on their diet. And of course, with the issue of arthritis and other disease processes or chronic inflammatory processes, get into those realms. At this point, we have finally gotten IRB approval. We have already had about 20 people come to their 1-hour session. We're ready to start drawing blood next week. We thought we would be done earlier, but our IRB at the University of Miami is a little bit slow. But now we're rolling, so we'll be enrolling patients and hopefully reporting back to you through either the newsletter or the next conference as to what we're finding in our results. Yes?
Dr. Woolger, do you anticipate that the findings from the study will be published?
Oh, absolutely. And the question was, would the studies of the results be published? That's a goal, absolutely. And I think what's fun for me is I see the information being in a variety of different journals, because the headache patients will be published in a neurology journal, and the GI patients are going to be in GI. We've got different groups, so we have a lot of different ways that we can get the information out to a series of different people. So I'm excited about that.
And do you have any anticipation on the completion date of the study?
Well, we'll already have, because the headache and GI portions of the study are only 3 months, that should not take us too long. One of the ladies who runs the GI clinic happens to be my patient, and she was very excited about doing this herself because she has headaches and she has diabetes, so she's going to be happy to enroll a lot of her GI patients. And the same is true with neurology. Our headache clinic is run by a patient of mine who has migraines, so she was happy to be enrolling her patients. So I think the GI and the headache will come out first because we had the shorter endpoints. Most published data on weight loss, if you look at studies for pharmaceutical products, really can check at 6 weeks. So we could have a very short, immediate endpoint. Although I'm also interested in finding out not only did we get weight loss at 1 month and 3 months, but also could people maintain it? Because that's of interest. It's not that helpful to lose weight for a month if someone's just going to regain it. So I think for weight management, we could have a short endpoint for a publication and then a longer endpoint, maybe an update at the end of a year.
What is your plan on withdrawing the Immuno blood test and as a follow-up? When are you going to get a baseline with?
Sorry, my question is you're going to get a baseline, but when are you going to get a subsequent one? Because IgG is supposed to be, it's like for example, a hepatitis B surface antibody. That's maybe a long-lasting antibody, whereas I don't know what to anticipate for this.
Well, it's some of the information we'll probably gain as we do the study. Initially, the plan is to just do the one blood test, and that would be it. But again, what I thought maybe for future studies would be we may find some people who respond very well for 3 months, and then their weight loss plateaus, or they don't still have the good control of diabetes or whatever it was we were measuring in them. For those people, we may go back and see if we can retest them and see if now they've developed any different sensitivities that have shown up, or if there are other interventions we can do. But our plan right now with the study is one-time blood draw per person.
I guess you can figure out if someone's like a rapid responder versus a normal responder. Maybe you could, I guess maybe there would be some genotype or something moving forward to figure out.
Right. Yes?
Could you wait for the mic, please?
Just important.
Are the patients required to keep a journal, and how do you measure compliance?
Well, we are asking them to keep a journal before entering the study and then after. I'm a little concerned that after the study they'll lose their motivation if they've gotten better. But what we've done specifically with the GI patient and the migraine patients is ask them to keep a 30-day journal before and then at the completion of the 3 months to see if we could document the actual numbers of days with symptoms compared to after having the diet change. The other thing that is part of that journal or that diary is if they did develop a headache or if they did develop GI symptoms, could they track back and document that somewhere in the last 72 hours they had been non-compliant with what their card said, with what their recommendations were? because that would be a good tie-in to say, look, we got them better. Maybe they're only 50% better, but on those days where they had the symptoms, they weren't following the recommendations. Yes?
Yes. Hi, my name is Dr. Cabrera. Besides removing the food allergens, is there any other consideration to improve patient symptoms? Because we know that's part of the gut function. We need to remove, replace, restore. So we're removing the offending agent, but for those patients that maybe do not respond fully, then we'll need to look, or it will be interesting to see what other factors they're missing in order to restore their function.
I completely agree with you. Just keep in mind this was our first attempt at documenting. I think we have a lot of ideas. I mean, I'm not opposed to doing cleanses on the patients and providing them with basic nutritional replacement, as we were talking about last time, replacing zinc and magnesium and things, because I think the people coming in with these diseases are so depleted and need so much help. But if we did too many interventions at once, we wouldn't be able to prove which was the intervention that was most effective. So I think that could be a staged approach to the study where maybe we could pick the non-responders and say these non-responders didn't do well, maybe they needed a detoxification for a month first, or whatever we decide as a study design. And hopefully, I was sitting in the audience last year and thought through this. I mean, hopefully people will hear this and think of additional ways we can't really add to the study we're doing, although we're going to have this information here. We could expand it onto something else.
You can do an arm.
Exactly.
For the patients that
Right.
haven't...
We'll be reserving the blood. We
yeah.
can take an arm of patients, responders or non-responders, if people have ideas, and we could do something with those patients. Yeah. Thank you.